Today, what I want to do is start talking a little bit about the cardiac adaptation to training. So kind of changes in athletes and changes with sports. This will probably take a few lectures, but let's start with some of the first things is like, well, in general, it has been said always that exercise is good for the heart. So, and there's clearly a lot of evidence that if you do some exercise, that your cardiovascular risk clearly goes down. Well, first of all, your body itself, your body composition, your insulin resistance and things like that goes down. So all of this will decrease, of course, your cardiovascular risk. But in general, because of this, especially your risk on ischemic heart disease and then heart failure related to it, yes or no, will clearly decrease with exercise. Now, the problem is a little bit what happens with a lot of exercise. So when you go, for example, to professional sports, and what you see there is that it seems like then it might be that your risk increases again, or at least your cardiovascular risk. And now the risk that is happening is actually arrhythmias. So arrhythmias and sudden cardiac death. So not anymore, of course, the ischemic cardiac disease or heart failure, but really arrhythmic problems. And of course, arrhythmic problems, if you get arrhythmias, well, atrial fibrillation is just something totally not nice to have. And increases the risk, of course, on thrombi and then stroke, and of course, ventricular arrhythmias, ventricular tachycardia, and especially fibrillation is, of course, really bad because you can do a sudden cardiac death. So the question is, what is happening here? Why do we see this? How do we detect this? What is causing this? And can we then also, for example, prevent this? And can we learn something for this also from clinical management? And so there's a couple of other interesting things that are interesting to look at this, and also how this is related, for example, with age. Because one of the things that you see, and that is like high profile deaths that you see in the newspapers and things like that, is when young people die on the sports field or something like that. And what you see there is, if you then going to investigate the reasons of this, what you see is that, first of all, there's a large portion, at least 1/3, which is related to a congenital and anatomic abnormality. So for example, congenital heart disease or something like that, that can of course be a high risk for sudden cardiac death or sudden failure of the heart. The other one is hypertrophic cardiomyopathy, and that's what we have been talking about before. So hypertrophic cardiomyopathy, because of the underlying genetic conditions. And then, of course, because you have these extremely thick hearts, which don't fill anymore properly if the heart rate becomes too high. And also you get these outflow tract obstructions. So we know that also hypertrophic cardiomyopathy is important. So especially these two, which is like a large proportion of the problems in young athletes, you could screen for in principle, because if you would do an echo in these, then you would immediately recognize this. If you do an ECG, potentially, although ECG is the way that we currently use it, not specific enough very often, but in the sense you could prevent this. Whether that's cost effective or not, that's a total different kind of discussion. Now, if you go to some of the other ones, so then you have this 14%, which is arrhythmias. Unfortunately, very often in these, you don't see any large anatomical changes. So there's a substrate here that we don't fully understand. And that is then, of course, much more difficult to predict. The other thing are related to, for example, in this case, infectious diseases. So there again, it's like we do not always know that much how sports and infections and especially myocarditis are related to these risk factors and so on. So these are also things that are still kind of a little bit unknown. So what we see here is that the majority is kind of totally explainable, but there's some that we don't really explain. And the question is, can these be related to the sports itself, or is there really an underlying disease that, independent of whether they do sports or not, that would be a risk factor? And this is one of the things that you want to check. Now, especially with arrhythmias, there is evidence that the more you train or the more exercise you do, the worse it will get. And here you see an example is the risk for atrial fibrillation. And what you see here is that the risk of atrial fibrillation increases with the amount of sports that you do. So there is clearly a dose effect, and that is likely that there's also like a kind of conditional effect, so that there's like a reason for the fact that these atrial arrhythmias are happening. Now, when we go to ventricular arrhythmias, which are of course much more dangerous, at least in the acute situation, what you see there is that there are actually, it happens. So especially in endurance athletes, they have seen cases of sudden cardiac death based on also and non-sustained ventricular tachycardias and syncopes. So it does happen. One of the things is that what is interesting is that a lot of these have criteria for right ventricular dysplasia. And right ventricular dysplasia is what they thought kind of, again, a genetic disease, a mutation of desmosomes mostly, so which is the proteins that connect the individual myocytes to each other and then get support. And what you see is that in patients that have this mutation, what you see is that their right ventricle over time grows more and more, and where the tissue is also being replaced by fibrosis or fatty deposition and things like that. But the thing is that over time, the right ventricle increases in size, the tissue decreases in structure, and related to that, you have the appearance of arrhythmias. So they very often call it like arrhythmogenic right ventricular dysplasia or arrhythmogenic right ventricular cardiomyopathy. So what you see is that a lot of these have criteria for the RV. So this suggests that there might be something going on in the RV, which is actually causes these arrhythmias. Because you wouldn't expect this, that you would look at arrhythmias and that the RV would be the cause. So there seems to be some connections between exercise and right ventricular problems. So this is already one indication. Now, another indication that this is something structural, or at least that you're doing some kind of damage, is the fact that in these cases where you have these severe arrhythmias in these athletes, when you stop doing sports, or for example, you do beta blocking, where you reduce the heart rate and thus kind of reduce also the chance of arrhythmias, this didn't prevent it. So this means that this is not something which is like easily reversible. This is not something that's easily controllable. It's something that is induced likely by some kind of permanent remodeling or some damage that you have induced somewhere in the heart. Here also, when you start looking at the remodeling, and here again, what seems to be the case is like when you look at the volumes of the heart, for example, and the ejection fractions, what you see is that also the ones with arrhythmias, they have remodeled right ventricles. So they have larger, much larger right ventricles, and they have less ejection fraction. So again, this also indicates that, that sports can induce structural changes that might be permanent, and that these structural changes might lead to the arrhythmia. And here is a study that was interesting then, as I said before. So what they saw is that in many of these athletes that have the tachycardia, there you see criteria, or there you see like a phenotype which looks like this arrhythmogenic right ventricular cardiomyopathy. And then the question is it by coincidence that these athletes just have more mutations? It could be that maybe you have this mutation and you like doing sports more. That always could be the case. But what they saw here is that the ones that do exercise and have these problems, and especially the ones that do quite a lot of exercise, you see that there's actually a much lower incidence of the mutation than you would expect in the case the remodeling would have been caused by the mutation. So that means that this is something which is not with an underlying, or at least in the majority, is not with an underlying kind of genetic explanation. So again, that's saying that it's likely induced somehow by the exercise itself. And then what you also see is that when you start looking at the risk of arrhythmias, you see that actually depends on the type of sports you do. And you see that it actually gets worse the more kind of severe and endurance the sports become. And there it's known that cyclists and the Nordic skiers, this is like the most kind of stringent kind of exercise that you can do, especially endurance exercise. And you see that the ones which are doing less exercise, you see that it's less. And for example, also if you take swimmers, for example, you see that's less because also swimmers are protected by gravity, by the water and this kind of things. So it's clearly different depending on the type of sports and thus depending on the loading that you have. So all of this again asks you the question is like, why do they have these arrhythmias? What would be the substrate? So what's the remodeling that is causing this? How is this related to the amount of exercise that you do? And how, for example, is this related to sex? And is this also something that is induced in everybody, or are some people more predisposed to it? Yes or no? So these are all questions that come up if you start to look at this data. So if you then start to think, it's like, okay, what's happening in these hearts? So which are the things that could be related to trying to explain what's going on? So what you want to do is you want to see is how are athletes' hearts changing with exercise, and how would this change with the amount of exercise, for example? One of the things that you see is that overall the heart increases. So you start to get a dilatation of the right and left ventricle. You mostly get also an increase in the muscle. So it's not only the dilatation, but at the same time, your muscle stays at least as thick, if not more. So your total mass of your heart is indeed increasing. And of course, related to the increase in size, you have an increase in stroke volume. What you very often see is that they also have an increase in early filling, as we said before. So if you have like a big heart that is very responsive, very elastic, where you store a lot of energy during the contraction, you get this fast relaxation. So you have very good early filling. So indicating that mostly the tissue itself shouldn't be too much damaged, because that's what you very often see. Now, the thing that you also see is that all the ECGs change. So when you look at an athlete ECG, it's very different. And also when you look at ECGs, when you try to interpret ECGs, you have to know whether this is an athlete or not, because some of the findings are related to the remodeling induced in the sports and some of the findings not. And so the question again is here also, what do they mean? So because what you have is, of course, when you change your size and you change your mass, obviously the electric wave propagation, which is in the end what the ECG looks at, is changing. So that is clear. The question is whether other things are changing also that might induce or might kind of explain these ECG changes. And this is still like for debate, but it's clear that the guidelines for interpreting ECGs are different for people that do a lot of sports versus not. But of course, the biggest problem is this induced arrhythmias, and very often caused by or with a right ventricular origin. And this is a thing that these are the things that are potentially dangerous. The other things are probably just a physiological adaptation and are rather good actually for the person than getting worse. So let's come back to some of the things that we have said before, because some of these concepts I think are quite important to look at. So one of the things that we know is that obviously the shape of the right ventricle is different than the left ventricle. And also one of the things that we know is when you look at the right ventricle has a lot of trabeculations. And also when we look at activation and so on, activation is also done through false tendons, and in the right ventricle it's especially also this apical activation, which is important. So here again, you see it. So when we look at these hearts, so normally the left ventricle is the elliptical one with the thick muscle with only a little bit of apical trabeculations. The right ventricle has overall much more trabeculations and is acting as a sponge, and also has a different shape. So the right ventricle, especially in the apex, is like pointed when it connects to the left ventricle. And some of the things that you can also see already from this is that clearly where the right ventricle and the left ventricle coincide, so where they come together, of course, there you have like in some ways a kind of almost discontinuity, although there is a kind of continuity of the kind of fibers and the cells, there is still a discontinuity in the shape in some ways. So this is something also important to keep in mind, and we can look at that later on. One of the things that you also see is when you look at this right ventricular apex here, is like the apex is really full of these trabeculations, which is good in a way because that, as I show in a minute, and we have been discussing before also, that's very good for volume ejection. But we see is if you start to get remodeling of this, it might become problematic at some point. And so here is again this slide that I showed you in one of the first classes. So where it's actually shown that having trabeculations is good in the sense that with trabeculations, what you can do is you can actually displace volume without having to deform the tissue of the trabeculation. So what you actually do is instead of that if you would have like a very smooth heart, you really have to deform the whole muscle in order to do the ejection. What you do with trabeculations is if you bring the trabeculations together, you actually decrease the volume just by bringing them together without having to do a lot of deformation. And it's less deformation of tissue needed to bring the trabeculations together than to really deform the tissue in order to do the volume displacement. The only problem is, of course, is like if you only have trabeculations, you don't have kind of a lot of structural integrity when you have high pressures. So trabeculations are extremely good in order to generate a lot of volume. Trabeculations are really bad when you have to work at high pressures. So that's why a left ventricle is less trabeculated than a right ventricle. So this is under normal conditions. So it seems to be that, or it could be that there's something happening that will make this different. And we'll come back to that in a moment, how this happens with sports. So besides these trabeculations, now we have to see is like, what is actually inducing these changes that you can see in these ventricles? And so what we said before is you see an increase in the size, and you see a little bit in the increase in the thickness. And so this is, of course, related to remodeling, because the only way that a heart can change in shape is if there's a trigger that induces this. So that means that the individual myocytes need to feel some triggers that would make the heart bigger or make the heart thicker, for example. And so we've been saying this before. So you clearly have two types, or typically you have two types of remodeling, because one is induced by an increase in pressure. And that means if you have an increase in pressure in the ventricle, and systolic pressure in the ventricle, what happens is that the wall stress, or the stress that the myocytes feel during the contraction, is higher. And that actually induces kind of factors that would increase the force development. And that means that, of course, you would have more contractile material, so that in parallel, so that you can indeed increase your force and thus increase the pressure in the ventricle. So that means if you have systolic pressure loading, you get kind of parallel replication of sarcomeres within the cells become thicker, and the ventricle, of course, overall the wall becomes thicker. When we have volume overload, what now happens is it's not the systolic pressure or the systolic stress which increases, but rather what happens is that you start to stretch them. So that means that your diastolic pressure increases, because what happens is, of course, if you need to increase your volume, you need to have more filling, and more filling is mostly induced in the end by an increase in atrial pressure, as we have discussed when we were talking about diastolic function. So when you have this increase in atrial pressure, what happens is that the myocytes get triggered in order to become longer. So you get like a serial replication of sarcomeres, and the myocytes get longer and the ventricle becomes bigger. So you have these two things that is happening. And so in order to understand why, of course, athletes' hearts get bigger, but also how this relates to the response to exercise, we have to always keep in mind that there's a relation, a geometrical relation between the size of the ventricle, the amount of deformation, and the amount of volume that is being ejected every time. So if we have a certain heart with a certain size, we have a certain amount of strain, that will determine the stroke volume. That's just a geometrical relation. And as we discussed before, if you have a bigger heart and you have the same amount of strain, what you then see is that, of course, the ejected volume is much higher, because it's always the outer rim of the volume which is being ejected. So that means that you have a working conditions of the heart, and I think that's shown here. So you have a working condition of the heart where you have a baseline value and you have, for example, an exercise value. In normal people, the size of the heart is mostly determined by the baseline value. Of course, most people, you do some exercise, but you don't do a lot of exercise. So that means that the heart will only remodel if you have a kind of chronic trigger for remodeling. If you do just exercise once, then the heart is not going to remodel to this. If you do exercise every day for a longer period with quite a lot of strength, then of course your heart is constantly being loaded. And that's the moment, of course, that the remodeling is going to take place. And so you will see that people are working. And one thing also, of course, to remember is that the total amount of volume of blood, so which is the cardiac output in general, is determined, of course, by the stroke volume, the kind of volume that's being ejected with every heartbeat, times the heart rate. So the faster you go with the same amount of stroke volume, the more you increase your cardiac output. And it's this cardiac output which is what is needed by the body. So your peripheral organs need this. You need to have enough cardiac output also in order to get enough oxygenation. And especially when you do sports, what you need is, of course, your muscles need more oxygen and more nutrition. And that means that you need to increase your cardiac output. So doing sports is in the end increasing your cardiac output. We'll come back to that in a minute, how you can do this and how these relationships are. But what you see is that in a normal heart, so you have a certain size and you have a certain stroke volume that is needed, and that stroke volume with that sized heart needs a certain amount of deformation. And what you then can do is you can, when you do exercise, there's several ways to increase this. For example, you can increase your deformation. So if with a certain heart you increase your deformation, of course you increase your stroke volume and you increase your cardiac output. Mostly this is not enough because you cannot keep on increasing your deformation kind of indefinitely. So what you need to do is also increase your heart rate. Now with an athlete, what happens is that an athlete starts with a much bigger heart. And that means that with the same amount of strain of that bigger heart, the initial stroke volume is much, much, much higher. Now, what is needed at rest is the cardiac output. Athletes, of course, they have a little bit more of muscle mass, but in principle at baseline, when you're sitting in the sofa, they are not needing a lot more cardiac output. So the basal cardiac output is the same, but because they have such big hearts that generate such high stroke volume, that means that they need to work, or they only need a much lower heart rate in order to do that. So what you see is that at baseline, the heart rates of athletes is much, much lower. And the reason for this is that they have a bigger heart with an intrinsically bigger stroke volume when they do normal deformation. So as an athlete, you need to have low heart rate. So this is also one of the things that you could look at, is of course, people that come in with a very low heart rate, either they have a problem with the activation, so with the intrinsic pacemaker, or they are indeed athletes with big hearts. So this is something which is important. But say now that this athlete is doing sports, what is happening is that, of course, they try to increase their deformation. But what you see is that when they increase the deformation, what you now see is that the stroke volume becomes even much bigger, because even percentage-wise, if you increase this deformation, of course, the amount of stroke volume becomes much bigger. And if they go to the same high heart rates, what you see is that they kind of can increase their cardiac output dramatically more. And of course, this is the condition that they are trained for. So this is the reason why they have these very big hearts, in order to be able to do indeed these cardiac outputs when they do sports. Now, one of the things that you see here now already is like, if these hearts are really so big and these stroke volumes are so big, your heart rate will not go a lot below 40, because if it drops even more, then it becomes unstable, and this is not happening. But what you sometimes see then, that actually the deformation, the amount of strain, is decreasing in athletes. And so when you look in the literature, there's conflicting information about this. So you see in some literature that they say like, okay, they measured the strain in athletes, they saw that the strain was lower in athletes, and they say, okay, there's ventricular dysfunction. Of course, this is not necessarily true, because the thing is, in order to keep the cardiac output, this is what is physiologically needed. And if they have these big hearts that are able to generate these enormous stroke volumes, then they just don't need to strain. And then there's also no reason to do these strains. So you have to be extremely careful when you're comparing this kind of deformations, only the deformation. You always have to put it in context. And so that's why it's always useful to look at the same time, as I've been saying before, you have to look at the size of the heart, you have to look at the deformation, and you have to look at the amount of stroke volume that this is doing and how this fits in the context of the patient. And when you compare populations, you have to take this especially into account. Now, the other basic concept that I've been telling before a few times also is, of course, the kind of, in a way, simplified Laplace wall stress. So that means that the stress for a certain pressure that the myocytes feel depend obviously on the pressure. The higher the pressure, the higher the wall stress, but it also depends on the radius of curvature. So the more rounded locally the myocardium is, the lower the wall stress will be for a certain pressure. And it's inversely related to the wall thickness. And one of the things that you can also see is that when we look at the efficiency of ventricles in order to generate volume, what you will see is that actually an elliptical ventricle is more efficient than a rounded ventricle. Now, what you see then is, of course, that the athletes want to be as efficient as possible. So that means that they try to remain as elliptical as possible, of course, at least as long as the pressure is not increasing too much. And of course, a disadvantage, as we said before, of increasing the size is, of course, that intrinsically the wall stress increases. Now, fortunately, what you see is if you do a lot of exercise, what actually happens is that you also improve your vasculature and that you see that actually the pressure is decreasing very often. So that means that at baseline, the athletes, although having a bigger heart, they don't necessarily have much higher wall stresses because already, of course, their pressures are down and everything is balanced again. But what you can see also from this is that you should look at these shape changes, because if there would be some kind of excessive loading, for example, during the exercise, you should be able to look at changes in shape that could be related to this. So that's important also to look at. And then one thing that I also said, which is important to keep in mind always when you look at exercise, is like, what is the normal response to exercise of the heart? And what you then see is when we look at contraction and contractile force development, what you see is that if you increase the loading or the contractility of the heart, what happens is that with that, the rate of deformation goes faster. So that means that you increase contractile force development, you increase your rate of deformation. The amount of deformation is different, in the sense that if initially you increase your contractile force development and you increase your heart rate, what happens is that indeed your deformation can go up. So that means that initially by increasing your heart rate and increasing your contractile force development, so in this case, a study with the butamine, but of course, that would be also natural if you do sports, you will also increase your contractility. What you see there is at moderate heart rates, or up to moderate heart rates, you see that the deformation increases. But afterwards, what you see is that the deformation decreases. And that's, of course, at the high heart rates. And this is now related to filling. Because what happens is that if you increase your heart rate, what happens is that, of course, your total cycle length goes down. In normal cases, without genetic mutations, you see that also your ejection time goes down. So your systolic time goes down. But what happens is that actually your filling time goes down much more with heart rate compared to your ejection time, because you still need the time for ejection. And of course, that time is related to the dynamics of your contractile material. You can increase that a little bit by increasing your contractility, but you cannot go super fast. I mean, that's just related to the material that you have. So that means that at the very high heart rates, which you might need in order to get enough cardiac output, what you see is that actually your ability to contract more, or at least to deform more, is actually hampered by the filling. And that's where you see that there's an optimal heart rate. And so actually you see some athletes that go to extremely high heart rates in order to do their sports. This is, of course, not great, because first of all, it's a higher risk for arrhythmias, but the problem is that's also then you work at a point where the heart is not efficient anymore. The most efficient athletes are the ones that do only a moderate increase in the heart rate, and then of course they have their optimal kind of deformation. So that brings me to the ways that athletes would adapt to sports, for example. So when you do endurance exercise, that means that every day you're doing kind of prolonged sports, for example. What we know is you need to increase your cardiac output. That's what intrinsically needs to happen. And there are several ways for it, as I said. So one is, of course, increasing your heart rate. The faster you go, the more cardiac output you have, with two disadvantages. What I said before, very high heart rates, potentially arrhythmic risk. Also, over a certain heart rate, you're not efficient anymore because you hamper your filling time. So you should only do this up to the point that you're going to kind of decrease your filling. The second way, of course, to increase the cardiac output is to increase the output of every heartbeat. So increase the stroke volume, which can be done by increasing the size. The bigger you become, the more stroke volume you can do with every heartbeat, with the disadvantage, of course, that if you become too big, then potentially your wall stresses go much up because of this Laplace stress. So you should partially compensate that, or try to compensate that with a lower pressure. But of course, the lower pressure in the end might make your system again inefficient. And then the other way to increase your stroke volume for a certain size is by increasing your deformation. But as I said before, that amount of deformation is again limited by first, of course, your baseline deformation. If you start with less deformation at baseline, of course, you can increase it much more, but you cannot increase it a lot over the moment that you start to get filling problems, because mostly you can only increase your deformation when you get some type of inotropic stimulation, which would also increase your heart rate. And then, of course, at a higher heart rate, you cannot do that intrinsically, the deformation. So it's this combination of size, deformation, and heart rate which makes your cardiac output. But of course, if you have like a 3-variable system, that means that individually, different individuals can adapt differently. And so when you look at, for example, a study, so this is, for example, some changes in heart rate, size, and the amount of deformation for a certain amount of stroke volumes change in this case. So if you want to look at these, what you see there is that some people, it's like say 1/5 or something like that of the population, is able to increase their deformation, increase their size, but don't need to increase too much their heart rate. And this is likely the most optimal way. But then you have people also that are absolutely totally not able to increase their deformation, don't increase their size neither. So the only way they can do their sports, and these are people doing similar amount of sports. I think these were marathon runners. So what you see there is that, of course, these have to work at these high heart rates. So you see now immediately that individuals, in order to do the same kind of amount of sports or the same amount of exercise, they do it in very, very different ways for their hearts, where one seems to be kind of benign. So if you don't increase your heart rates too much, that's great. Your size can increase, and mostly if you decrease your pressure. So this is never going to be a problem. And of course, increasing your deformation is always good because that's the most efficient. But here, these guys, because they have these high heart rates and they're not able to do anything with their sizes, potentially these might get in problems. And this already tells you that when you look at this type of populations, because there are all these different mechanisms to adapt to what you need to do, there's a high probability that all these individuals will really show different phenotypes. And this is a little bit also a problem of many of the studies. If you're now going to do a study where you look at patients or individuals in this case that do the same amount of effort, the same type of sports, and then you would measure their strains, their deformation, and their heart rates, and you would take the average of the population. Of course, what you're going to have is you're going to have a certain number with a large standard deviation, but it tells you nothing. And also, if you compare different types of exercise, for example, and you only look at this average, of course you have a potential problem because there are different ways to adapt. So what you really should do is you need to go back to the understanding of, okay, what is happening? How can we kind of deal with a certain situation? Are individuals doing this differently? And if they potentially do it differently, what you then need to do is you need to do rather a kind of more like pattern analysis in some ways, or at least to see how this is distributed within your population rather than just doing averages. And this is also, again, when we come back to some of these kind of machine learning techniques and so on that we are doing, this is exactly some of the reasons why we're doing this, because of the fact that a certain kind of overall stimulus, for example, can be done in different ways. So your phenotype, in some ways, how you adapt to that situation can be hugely different. And that's why you cannot pool these. You really have to go back to what are the mechanisms? Can I unravel these mechanisms? Do individuals do this differently? And can we then look at this? And then, of course, when you start to look at individuals and you start to look at images, then you see big differences. And so here are two individuals where you do before and after a challenging race. I think this was with some of these kind of crazy sports that people are doing. I think this was here in the Pyrenees, where they do like a marathon or half a marathon, while at the same time going up and down the mountains for 1,000 meters or something like that. Something which is totally crazy, but okay, some people like it. And if you then look at two different individuals where they did an echo before they started the race and just when they came back at the finish of the race, here you see, for example, if we concentrate on the right ventricle, you see here this right ventricle is a little bit of hypercontractile, but in general you see that both the shape and the size are roughly the same. So, and the amount of deformation is rather increased than decreased. Here is another one where you see that at baseline, when you look at this, you see already that here, this ventricle looks different in shape. So you see already that this is a much more spherical ventricle. Potentially also, when you compare the size of the ventricle with the size of the atrium, likely the atrium is also a bit increased in size. But if you now start to look after the race and you look, for example, here at the ring, the tricuspid ring, you see that this ring displacement is much, much, much less than here, for example. Here, this ring vigorously moves from base to apex. Here, it's still moving a bit, but it's virtually stationary. And also when you look at this heart, it starts to have this kind of more the radial circumferential deformation rather than almost exclusively this longitudinal one. And also when you look at the size, and even when you look at the sphericity, you see that here, this one kind of increased. So you see here two individuals that did exactly the same race and that in principle have exactly the same amount of training, but you see that hearts individually kind of adapt very, very differently. And these are the things that we actually have to study in more detail, is why is this happening? Why is this also predominantly in the right ventricle? So as we can we'll show later on, this really is predominantly in the right ventricle. And how could we assess it? And what are the potential problems, especially with regard to arrhythmogenic changes? But you can see already that just looking at this image, you might say, okay, the fact that we saw in the beginning that there's epidemiologically an increase in arrhythmias in some of these athletes with suggestions of a right ventricular origin, you can see that this type of remodeling really could be indeed related to, or could be kind of potentially a substrate for these remodelings and these arrhythmias later on. Okay, I think that's enough for today, and we can continue next week afterwards. Do you have any questions at this moment?
Bart, hi. Thank you. I have a question. So the findings that the right ventricular changes that we were seeing in the IUGR were resembling that, no? So without exercise, these right ventricles resemble the ones from the athletes. Was something like this, no? So they look like the bad ones.
Yes, but yes. The thing is here now, you have to see is that's where in one of the next sessions, probably the next, we come back to what is the cause of this change in the right ventricle. And actually the cause is likely that during exercise, some people have very high pressure loading in the right ventricle. So it's really the pressure loading that would be inducing the abnormality and the remodeling. And there again, that's the same thing as you would see in the growth restricted. So there they have intrauterine pressure loading. It's not that these fetuses do more exercise, but so here it's, again, we see a phenotypical remodeling, and what we need to see is like, okay, what is the stimulus that causes this? And mostly, as I said before, what you see with pressure loading is that you get more spherical, for example, and that you have less ability to do the deformation. So you get the same type of remodeling because the initial stimulus is the same. The induction of the stimulus can be through different ways. So you can have a valvular problem. Your exercise, actually, what we will see next time is that if you increase the volume through the lungs enormously because of the compliance of the lungs and the kind of the non-capacity to store blood, actually you see that you have high pressures there. Or in the growth restricted, it is because you have an increase in the placental resistance, plus additionally an increase in the volume, which both will lead again to pressure loading. And it's this pressure loading that induces the remodeling. Thanks again for listening. See you next week.